Okay, I think that's my cue. Thanks for joining us today. I'm pretty excited because this is one of my favorite topics. We're going to talk about how consumerism is currently being applied in healthcare, and more importantly, all of the ways that it should be applied going forward. So, I think when we talk about consumerism, you think about it from an economic perspective. You think about things like fast fashion and, the demand for additional goods and our desire to acquire as much property and things as possible. But when you look across different industries, consumerism has driven a lot of different kinds of trends that are really positive. So the auto industry, the ability to now know more about what car you're buying, perhaps, than the dealer who's selling it to you. When you think about things like the requirements for nutritional labels on food packaging, all of those things have come from the demands of consumers driving change in different industries. And so today we're going to talk about how that affects the changes that we need to see in healthcare. And I think, all of us in this room are consumers fundamentally, and we forget sometimes, I think, how involved we are in this consumerism lifestyle. So as I ask each of my fun friends here on the panel to introduce themselves, if you want to use your camera, you can go ahead and scan that QR code that's up on the screen, and it will pull up a poll for you. So in the last day, have you made a purchase on your phone? We'll let you go ahead and keep responding here. I'll tell you my own quick story. Stephanie Trunzo, SVP of Oracle Industries. Prior to working at Oracle, though, I've also had my own startup that was focused on mobile tech, very, very involved with consumerism across different industries. And I remember now, probably, 8 years ago or so, when I got my first Amazon Alexa. And I was in the shower, and I ran out of shampoo while I was in the shower. And I was able to just speak out loud, reorder shampoo for me. And that was a moment where I really realized that the world was going to change in the way that we interacted with technology, and how truly user experience is everything now. It's everything you touch, and it's everything around you. So why don't I go ahead and flip over here to Hillel, if you wouldn't mind giving us an introduction and tell us what you've bought in the last day on your phone.
I'm just imagining that you ran out of shampoo in the shower, and you said out loud, reorder shampoo, and then the drone flew
next.
in the bathroom window and handed you shampoo. And you're like, thanks. That would be perfect.
Yep.
So we're almost there. Hi, I'm Hillel Cooperman. I'm a designer at Oracle, and I, along with Jenny Lamb, who's not here today, we co-lead design for Oracle. We're, I think the fact that there are two SVPs of design at Oracle, it's the first time there's ever been any senior vice presidents in charge of design at Oracle in the history of the company, is kind of a sign of Oracle's commitment to making the end user, the consumer that we're talking about, sort of at the center of our investment in healthcare, making sure that they're really caters to their needs. As far as what I've bought, I'm embarrassed to say there are multiple things, and I don't even remember. Because it's just so easy.
No, I think that's the point. That's the exact point, yes.
I just bought a bunch of stuff, and then I don't remember, and then the packages show up, and sometimes I wonder, what am I even doing? I don't know. This maybe is a topic more for my therapist than for this.
Yeah, no, I hear you completely, and I certainly have the moments when I arrive home and there are so many boxes on the doorstep that it is like a surprise to me when I open them what is going to be inside. So I hear you on that. Mike, could you tell us a little bit about yourself and your company, and what filthy buying habits do you have online in the last day as well?
Sure. Mike McSherry, CEO of Zeal, and by way of background, Zeal is my sixth startup I've co-founded. Several have become large mobile and tech companies. Boost Mobile, I co-founded that, and My last company was a company called Swipe, a touchscreen keyboard that was put on several billion phones. Now it's on every Android and iPhone in the world. Anybody use it? Familiar with
Me.
it? Yeah. All right. That's quite interesting in that Swipe was invented pre-touchscreens. It was meant for people with disabilities, paralyzed people. Like think Stephen Hawking, he used to have to do a puff on each and every letter with some eye tracking software. And so then someone challenged the founder, the CTO of the company, to invent something that could help with the continuous eye trace. So we worked on that for years to help overcome, a challenge for people with disabilities. And he came up with that, and then next thing you know, the iPhone came out and the whole world blew up on touchscreen, so now it's a modality on every single phone in the world. Well, I take that learning, Alexander Graham Bell invented the telephone to help his deaf wife communicate. Many, many technologies have been invented to help people with impairments and disabilities use technology, communicate better, and that's healthcare. All of us are dealing with impairments, disabilities, limitations to some degree. Technology helps people overcome that, and that's what we're trying to solve here. So I used my learnings in mobile and technology to jump specifically in healthcare, and we built Zeal, which allows clinicians to prescribe digital apps and tools and services. So instead of just meds being the only therapeutic that help patients, we let them prescribe apps that might be related to their pregnancy or diabetes or behavioral health, or devices that manage their sleep apnea or diabetes with glucometers. So we're embedded in the EHR to let clinicians prescribe and then subsequently monitor digital health tools and services. But we've also done like meal delivery services for oncology surgical patients or post-bariatric surgery patients. So what constitutes health is broad and all-encompassing, and we'd like to think we help extend the EHR to facilitate that. With regards to certainly the flights and hotel reservations and things like that are traditionally e-com. But yesterday I bought an anchor, 25-pound anchor on Amazon, ships to your home. Great, fine.
You have a boat, right?
I have a boat. And when you have a boat, you buy lots of obscure shit.
You didn't just buy an anchor, did you?
Yeah.
He's buying the boat on Amazon next. He's starting with the anchor.
I bought a Tesla last year online. Like, what aren't you buying online nowadays?
Yeah, and I think, you said a few things there that are pretty interesting, but the expanse of what health means, and when we connect the dots to consumerism, fundamentally, all of us in the room are consumers. All of us in the room have a body. All of us in the room have a mind. All of us in the room have loved ones. That makes us part of the healthcare system as much as it makes us consumers. And, we think about all of the trends that we see around even the things that we just mentioned: convenience, personalization, the ability to understand your own information, your own data, own your own information. Mike, could you maybe kick us off a little bit on that conversation about how some of those maybe macro themes of consumerism are being applied or need to be applied in healthcare?
Well, the challenges to use healthcare is often the who pays and who's responsible for bills. And so now that you have high deductible health plans and there's more and more people doing independent research with Dr. Google, people are starting to become more and more consumer oriented. However, it's not always the tools are available or easily accessible to individuals in trying to be the consumers. There's a information asynchronicity, or asynchronous information on what's available and transparent with pricing or information or availability versus what consumers would like to see. I take a look at, there's new front door strategies. Maybe if we're all in healthcare, we've kind of heard the race for the new front door, who's trying to attract that portal. Google and, Amazon and Facebook have all tried to, capture the portal level of effort. But the thing that I've never understood in the world of healthcare is you've got these massive brands, Mayo, Cleveland Clinic, et cetera, and they tell their patients to download an app called MyChart. Consumerism starts with the mobile device. They're outsourcing their brand to some third-party brand name. It'd be like Starbucks saying, hey, start with my coffee and scroll through Tully's and Pete's and et cetera, until you get to the Starbucks experience. And then they've outsourced their experience. I can't possibly fathom how these large provider systems have outsourced their main consumer channel. And so if you want to start with consumerism, you have to start with offering the access, the ease, the tools, and invest against that. And I think that's one of the challenges that we're seeing across the industry now.
Yeah, I think you're speaking to the fact that how far behind healthcare is as an industry in understanding what it really means to be able to present a digital interface that represents who they are and that they actually have a connection to their patients as customers. And one of the things that I have talked with a lot of those health system CEOs and leaders about is building up a different muscle that they've not had to build up before, not necessarily having, a CMO or digital organization that's thinking about themselves in the same way that, say, a brand would. To your example, Starbucks is not generic coffee app that you scroll through to find Starbucks. What would you say, before I kind of ask Hillel to chime in on some of the other industry examples, to how organizations have to think differently in order to be able to address some of the things you just mentioned? How are they thinking about shifting the way they hire, the way that they have, I think now I'm starting to see a trend towards health systems having real chief digital officers and, thinking about that in the same way we might expect a consumer brand company to build their talent.
Well, much like big box retailers or, think Sears and Kmart if you want to use those analogies, or, any other large scale aggregated information. Hospital systems used to think their brand, their hospital on the hill, it was the default, everybody went to it, there was no other consumer choices or options. And now you've got Amazon buying One Medical, you've got all these private equity backed primary care efforts, you've got all the retail players, Walmart, Walgreens, CVS, all trying to get into these patient experiences, these low acuity services. They're trying to capture the initial the front door. They're trying to capture that first patient experience and then route the patient downstream from that. And if hospital systems lose that initial first touch with their patients, they don't offer a convenient option, they don't offer a lightweight telehealth experience, they don't offer a low acuity retail setting, they don't offer an ambulatory surgical or MRI setting or whatever, then they're going to lose that first touch with patients, and then all the steerage and routing is going to bypass these expensive hospitals on the hill and their fancy buildings and things like that, and they're going to further deteriorate their positioning. So they need to evolve with the times, like all these other big box efforts, and if they don't, they're going to be just subjected to ER trauma centers and maybe tertiary care like surgical centers.
Yeah, and maybe something to come back to too is just the number of direct-to-consumer companies that are cropping up that are filling in those gaps already today. But Hillel, one of the things that we've kind of thematically seen is that where other industries have embraced some of these consumerism concepts more quickly, are there places, in your work across Oracle and across the different industries that we serve that just immediately come to mind for you where we could be applying those same learnings in healthcare? Technology is not the problem fundamentally. The technology exists, our understanding of it exists. What are some things that you could speak to where you've seen our work in other industries make an impact?
I mean, it's so funny. Like it's almost scary for me to say this because it's kind of like, duh. But I really think that when we are in this system that we're in, where we're at a big company or even a small company, and we're trying to focus on the bottom line and make a business, and we just lose sight of this fundamental of who we're focused on and how they're feeling. Like how they're feeling. And one of my favorite examples is taxis and Uber. And I'm not saying that Uber's perfect or not. I'm not commenting on that, but in the moment, nobody liked taxis. No one. No one was delighted by that experience. And then you're like, oh crap, I'm fumbling around cash. Maybe I'm dating myself, but they didn't all take credit cards. And you're screwing around with that, and you gotta run to and so I just think that we have two populations in healthcare, neither of which is primary concern is money. Who, if we focus on them, the money will take care of itself. And I know it's easy to say, but if we focus on the patient and how they're feeling, which I think primarily is often scared and worried and confused, and the other population is the provider, doctor, nurse, physician assistant, medical assistant, person at the front desk, who is like, these are hard jobs. A lot of these jobs, they've gone to school for a long time for. They have lousy hours. Sometimes we talk about, the pay is great. It's not as great as you think. And they're doing it in a lot of cases because they care. They care. And so, and all throughout the day, they are being burdened with tasks, or often what feel like taxes, burdensome taxes that are distracting them from the reason they're doing the thing in the first place. All so that the right code can be put into the system, so that the money can flow in the right direction, which I am for. We got to get, yes, I get it, we got to do that. But if we start with that, we miss the opportunity to make the experience focused on those people. And so I guess sorry, I didn't have time to write you a short answer.
No, I like the answer.
So to me, what I always try and start with, and we do this, we're really working hard at Oracle to do this in everything we do. In everything we do is, okay, let's put aside our concerns as a business. Let's just put, not forever, not get rid of them, not forget about them. We are a business. Just put them on the shelf for a second. Let's put a pin in them, as we say sometimes at corporate speak. And let's think about, who is this for? What is their state of mind? What are they trying to do? And at the end of them doing it, how do we want them to feel? And if we can achieve that, I promise the rest, we'll figure it out. It will take care of itself. I promise it will. So that is the lesson that's the lesson we're trying to bring. That's the sort of little evolution we're trying to bring to how we do things.
It's a reframing, and I think that reframing, a few things you said. First of all, even transportation is part of healthcare. When you think about the journey, right, that exact same feeling and wondering and confusion and anxiety could be about getting to a hospital or getting to your doctor's office or not being able to get the right kinds of transportation. So,
we've prescribed transportation Uber rides to patients.
There you go. So, there's no understanding what the journey around healthcare looks like. It's almost like there's no real start and stop point. So figuring out, to your point, thinking about the mind of the human and how that human, what context they're going to be in, we are able to take these decades-old systems that were built for transaction processing, and to your point, not that they're not needed, but like many other industries, if you follow the dollar, you can see where there are inefficiencies. You can see where you could potentially have new opportunities. You follow the dollar in healthcare, and if that's your main focus, you're going to get to all of the wrong answers. So this industry is different in that sense, and I think our goal of being more patient-oriented, more human-oriented is very much about shifting that lens from a system of record into one that is about system engagement, about thinking more intelligently about how you can use technology to do the work to accelerate what a human might have to do at the end of the day. So, that kind of comes back in my mind to, to something that we were just about to chat about with these other direct-to-consumer companies. We go to some of the bigger healthcare shows, and I think we may have even talked about this at some point, but I look at the floor, the showroom floor, and there are hundreds of vendors, and 90% of them are making a business on fixing the gaps in the existing systems. 10% are innovating or trying to think about the humans in the story. And I think those of us that are invested in this conversation want to see that number flip. It should be, 10% that are making a business on fixing things and 90% that are innovating on, okay, how do we prescribe an Uber ride for a human that needs that kind of transportation? But there is this big shift with direct-to-consumer companies, Aura rings or getting your prescriptions. Instagram tells me all the time about the prescriptions that I need. So, what do you think about what we're seeing in the shift towards not just consumerism concepts, but actually companies that are direct to consumer to fill some of the gaps that we see in our primary health systems?
Well, I'll come back to the direct-to-consumer, but I'll riff on something that Hillel said, and then you reiterated. Honestly, I think 90% of the problems in healthcare could be resolved at a business model level. It's not technology. You could create the Uber-like experience. You could create the Amazon-like experience. All of that is available to us to build. It's just the business model falls down. This, multi-party payer system, prior auths, denials, claims, all of that stuff is to accommodate the complexity of our insurance, setup and reimbursement schemas and things that we have in healthcare.
In the United States.
Yes, in the United States. I'm sorry, I'm speaking from a U.S. lens here, and so I've heard old hats in healthcare say nothing happens without legislation, without regulations demanding, requiring, enforcing. Nothing happens, and so you could just throw a wet blanket on, well, there's going to be a change in administration, let's see what happens. But if you removed all that complexity and you went to a far more simpler system, you'd see all of this consumerism and innovation flourish in these consumer experiences. And the joy back to the clinicians as well, because they're the ones wearing the hassle of being glorified data entry clerks and processing things just for the billable events and things like that. Bills have to get paid. No margin, no mission, and so that's the world that we live in. So I would just say, lobby, congressmen, Senate, legislation, simplification. That would resolve a lot of the complexity that we're trying to speak about here, because it's not a technology problem. It's typically a business model problem. Now, so direct to consumer. Certainly during COVID, you just saw the rise. You've got Hims and Hers and Ro. That are trying to be this, low acuity and, ED pills and fertility and things along those lines. You've got Amazon, who's sort of the king of consumerism, now getting into, healthcare with having bought One Medical and dabbling in a lot of other clinical services. And in our game, Amazon is now the third biggest ad revenue collector in the U.S. Google, Facebook, Amazon. So when you see all the sponsored ads on Amazon, they're now showing ads related to you search for a scale or blood pressure cuff, and they show ads for Omada, a diabetes management solution. And presumably they're going to add others, and they're going to add MSK solutions and behavioral health solutions. And so Amazon's they're checking eligibility to see if it's covered benefit for you, but they're using their consumer presence to route patients. You talked about influencer marketing, Instagram, Facebook, that is influencing. And the king of direct-to-consumer is, pharma. They've always said, ask your doctor. 9 out of 10 doctors recommend, we believe this is, beneficial for you. Ask your doctor. That's the whole schema of pharma, is to sell more pills and drive, brand awareness and try to drive that consumerism demand from that, point of view. But I think where it's all leading, and this is the opportunity, payers are now, then large insurance companies, Optum's buying, clinics around the world, they're all standing up telehealth. Everyone's trying to attract that first patient experience. And hospital systems control over, I think it's almost 60% of the doctors in the country work for a large hospital system or academic center. And so with that data, it's hospital systems to lose. That's sort of the market I play in, and who I'd like to assist the most, because I would like to think that you have a doctor and a patient, and why do you need all the middlemen in between? Why do you need all these insurance and claims processors and everyone in between? But that's the way it's set up. So hospital systems should be capturing that patient experience. They should be providing the ease of how that patient wants to engage with that system, be it telehealth or online scheduling or low acuity urgent care, or the higher end surgical care. I saw a point of view kind of meme the other day. A patient thinks, I'm not feeling well. Let me start with Google. Let me ask my friends. Let me look online for something. Let me go to the low acuity urgent center that's easy for me to get to. Then. And the last thing they think about is the hospital system being in an inpatient experience. Whereas hospital systems, they're trying to fill those expensive beds. And they think with like, okay, let's fill the beds, let's manage inpatient, okay, then let's manage surgeries, and okay, let's manage outpatient, and then. Last thing they think about is brand awareness and consumer experience and their presence online, how consumers are gonna find them. They have to shift that thinking if they're going to maintain relevancy in this new world, because patients are looking for consumer ease. That's the way the world works. And if the incumbent players aren't offering that, patients and consumers and however you want to define yourselves, they're going to slipstream around for whomever provides the most convenient experience, and that's going to be their default into the future.
Yeah, and you mentioned about policy and regulation and all of these things that end up being, I think, rightfully, I agree, the difficult parts of these changes rather than technology. I believe that one of the real benefits of consumerism in healthcare is that it's going to be all of the humans driving the changes that are necessary because they just expect things to work differently, because that's what they see happen when they're buying anchors and checking into their hotel and everything else. But there's also a change or a shift in asymmetric information. So when you start getting transparency, it changes the power dynamic in the players that are part of the system as well. I can walk into my doctor's office now and show them all my Oura Ring data and ask them what to do about it. I don't know, they don't know. So part of this change, I think, is also, and Hillel, coming back to your point about thinking about the humans, how are we going to educate and not inundate with data that is available but maybe not relevant? Technology is not the problem, but it could be part of the solution here. So, Hillel, could you maybe chime in a little bit on how technology can help us with these problems, that even when we get to a point where we can connect data, even when we get to a point where we can start leveraging, not just vanity data, but data from wearables and these other kinds of direct-to-consumer or even medical devices at home, how can we think about not making that a mess for people?
Yeah. I mean, when a problem is really big and complicated, like this one, I like to just say, okay, well, let's just bite off a little chunk first. So I don't know how to solve the bigger problem, which is, how do you take a human being who did not go to medical school and give them access to all the data about their health and not scare the hell out of them, confuse them? I don't know how to do that. What I do believe is that the first chunk of the problem is, I do think you should put them in control of their data. I do think that having access to a unified, patient-friendly view of your entire health history is a place to start solving that problem, and and at least giving you the feeling that you are in control of, hey, I know what's happened to me. Like, I mean, just even they're like, when did you get your last tetanus shot? I don't know. I don't even know who to ask. I have no idea. Is that the one that used to leave the little round mark? Do I have a round mark? Which arm? I don't know. Like, I don't keep track of this stuff. Like, isn't that your job? I want to say to the doctor, isn't that your job? And they're like, no. And I'm like, whose job is it? And at the end of the day, you realize, I think, when you have something that's more than a minor health issue, or someone you love has more than a minor health issue, you realize it is your job. Yeah. It is your job to be the project manager for your health, and that there is no one provider who's going to kind of take responsibility for you. And so I think the start of that process, I don't know how to not, I don't know. But the way I would go down the journey of solving that problem is, okay, let's start by aggregating all the information in one place. Let's look at all the information we got. Let's figure out what is a patient-friendly version of each piece of information. You know, like, sorry, just to go on this a little bit. Yeah. One thing that we were looking at designing the other day was, okay, what happens when a lab report gets released? Well, if it's normal, and by the way, this is also funny, you know, what does normal mean even? But when it's normal, like usually the patient receives the lab. They get a text, oh, it's in your online chart, and you can go and look, and then you've got to somehow be like, oh, is elevated good? Elevated's good, right? I'm elevated. No, that's not good. So you have to figure out what good is, but usually you get it. But then sometimes when the result, I literally had a friend just get this, she saw her result and it was bad, and they just let her see it without any explanation. And so we're looking at this notion of how the result can be embargoed until the doctor has a chance to communicate directly.
Interpret or translate, yeah.
And to call, like with their voice.
A human, yeah.
Yeah, so they could talk to a human, and that there is also gentle but consistent pressure on the physician. Say, hey, it's been this many hours since this result has come in, and your patient is waiting to hear this result, and they haven't yet because you haven't called them yet. And the moment you do, you can press this button, and then once you've explained to them what they're about to see, you can release the results to them. And these kind of ways of curating the experience, gently, you know, progressively revealing information with an expert along for the ride are the kind of things that I think about that the techniques we'll use to make this slowly easier for people to digest.
Yes, it makes total sense. I think that, you know, and to your point on what is normal and what, you know, how do you interpret these things? I think these are some of the places where technology can make a big difference, because let's take, you know, one of the trends of consumerism around personalization.
Sorry, there was a Seinfeld episode where George gets his result and they say it's negative and he's freaking out. They're like, no, negative's good.
Yeah, no, that's yeah. I mean, well, we're living in Seinfeld moments all the time, aren't we? But yeah, I think, you know, technology is going to be able to do things like allow us to have smarter baselines that are personal to us versus kind of generic application of what normal looks like. Because normal for you, normal for me, you know, those are two different things. I think the other place that I see technology helping with this problem is, you know, embedding those systems of intelligence so that, you know, machines can make sense of a lot more data than a human can a lot faster. And how can we use things like AI, which is, you know, obviously not new, but we're talking about it a lot. And there are new ways of applying it to help with some of these problems. You know, Mike, what are your thoughts on how AI can help with some of these challenges around just the mass amount of data and where's the signal from the noise, and how do we make it understandable in human language?
So back to the prior company, Swipe, we sold that to Nuance. Turns out text input recognition is kind of the same thing as voice recognition. Language models, you know, dictionary, we supported 99 languages around the world. And so at Nuance, I worked there for 3 years managing their voice rec portfolio. At the time, Nuance powered Dragon and Siri and Alexa, and so which is now voice grabbing, right? So it's become front and center in the world of healthcare delivery. And so as you talk about you know, AI enablement in healthcare, I mean, you can talk about any sort of like dimension of it. Doctors are using it for voice scribing. It's, you know, you put a phone right here, it's listening to the conversation, and it's spitting out, it's form filling the notes instead of the doctors having to type all of that in, you know, themselves. I had a very interesting conversation with, we work with dozens of large, you know, provider customers, and you know, from Providence to UPMC to Mass Gen Brigham to Duke, Stanford, Banner, MedStar, et cetera. Memorial Hermann, you know, back in the room, thanks Lucky. And so with that, we had a discussion about how these hospital systems are using AI and claims processing, back office automation, scenarios like that. But it came to voice grabbing. And this was back to the problems in healthcare. it's one of the vendors, I won't name them, charges $4,000 per year. But they were saying, Bart, all data shows saving an hour of clinicians' time per day, an hour of a doctor's time per day. Like, holy crap, everyone talks about physician burnout and, physician efficiency and, like, let's decrease the burden of work and pajama time on, EHR charting over the weekend, et cetera. $4,000 a year. And they're like, yeah, we only have like 50 people using it. I have 500 people on the waiting list to expand the pilot, but we just can't afford it. I'm like, well, $4,000 a year, that's like $20 a day. Wow, $20 to save an hour of time? That seems like pretty good use of time against physicians. And they're like, yeah, but we can't afford that. That would be $20 million at our system. And so we'd have to ask the doctors to see more patients. And that's a non-starter because they're already burdened and worked out. So we can't ask them to see more patients. So we're just going to slowly expand the pilot while we figure out how we can pay for it. I'm like, well, $20 a day, I think a lot of people would pay that out of pocket if it's going to save them an hour of time day, or time savings or whatever. And like, yeah, we don't want to open up that can of worm because then it demonstrates that we're not actually supporting our physicians and we have to make them pay out of pocket. So it's this like chicken and egg scenario, like an hour time saving per day, and you're not going to just give that to all of your doctors? It comes back to the money, and that is tragic. It's tragic to hear that, and that they're in this endless cycle loop of figuring out how to pay for that when it can bring these productivity gains. I heard something on a podcast the other day. Some company is using AI at customer service. Chatbot is answering email and SMS questions, and they saved $40 million in 1 year at customer service operations. Like, wow, that's great. This one company saved $40 million. But a public company that specializes in call center operations lost $2 billion in market cap because they just said that company's not going to need all those resources, bill all that, AI is going to replace that. So it's the second order ramifications. Someone in healthcare is going to use it to save, tens of millions of dollars or $5 million here, $3 million there, but it's going to affect everyone else around that. So call center operations in healthcare, claims processing, prior auth, clinical workflow, documentation. We leverage it in discerning what is eligible or relevant for this patient. We've integrated 70 different apps, tools, services, Uber rides, meal delivery, whatever. So what's relevant for a patient? It depends on their clinical conditions. It depends on their payer eligibility. It depends on their prior history. It depends on their comorbidities. It depends on their medications that they're taking. All of that helps to discern the relevancy for this patient. We try to do that more to solve the clinical workflow burden of doctors having to think about that and process all of that. Or we've all seen doctors handing you or nurses handing you photocopies of PT exercises or, here's how to prep for your surgery and like some, pamphlet of, thrice photocopied images where you can't even discern or read.
You used the word thrice. I just want to note. That's it. I'm happy to hear it in usage. Go.
All right. Anyway, it's just the burden of manual, laborious processes in healthcare. Automate that. Saves clinician time. You get more of that patient face-to-face interaction, which is what the patients want. They didn't come here to see their doctor like, what'd you say? What'd you say? What'd you say? They want to have a one-on-one conversation. That's the joy of medicine. That's why so many clinicians, I think, get into medicine. But they've been subjugated to the demands of and the rigors of, frankly, billing. Back to that voice scribing solution, the dirty little secret is it captures more information in that in that patient experience that it actually processes more billing. So I heard 20% higher billing codes using voice scribing than what doctors might type in themselves in remembering and capturing all the conversations they had with that patient. So you'd think for that reason alone it would get proliferated on a more broad level, but still, how do you come up with $20 million to improve the productivity and efficiencies of my provider group? So that's the perverse incentives that exist.
The struggle, yeah. I think people want, when we talk about AI and all of the cool things that will change the way the patient experiences healthcare and their healthcare journey, everybody wants to go to the science fiction level way that you can apply technology to do things like have the drone bring me my shampoo in the shower. And look, I'm all for it. Like, that would be great. But there are a lot of things, to your point, that we can do today that really help with efficiency, that help with the cost savings, that help with the transparency, that help with the expectation setting that Hillel was talking about. Just even doing the things like ambient listening, paying attention to the data that you can get, even if it's a human that doesn't want to be with another human in person. Like, my daughter would prefer to chat with somebody on text. But you're going to get more background information, even from visuals, like, oh, there's a cat in the background, and so maybe that's a relevant medical data point. Or we happen to notice, there's other data we can pull in from social media that tells us things about where this person lives and, what factors could be going on around them that impact their health. So maybe switching from technology just for a minute, and we'll open up to the audience in a second, but we think when we talk about consumerism, we talk about patience, I think our minds naturally go to, I'll just say, people like ourselves who carry around these little computers in our pockets every day and, make purchases on them. Most of the people in the room bought something in the last day. But there is an entire, very expensive population of people that are not digitally enabled. So that still makes them a patient. That still makes them part of the healthcare system. Hillel, from a human-centric perspective, any thoughts on how do we use technology to help people that don't have technology?
I mean, I think we provide it for them.
Yeah.
And I think, in cases where they're not facile with it, we provide people to interface with it for them. Like, I think, we think a lot about accessibility and inclusiveness, and I think those, especially when it comes, like, it's just not a choice. It's not an option here. Like, we want the experience to be as good as possible for everyone. So I think we really need to always be thinking about, like, if you don't have a phone, if you don't have that ability, we're going to provide it for you. We're going to raise the floor.
Yeah.
For people, and I think that's doable. I believe that, and I think at the end of the day, let me put it this way: I think it's easier to have. I think it's cheaper and easier to have a couple of tablets in the waiting room for people who don't have a phone than it is to have an alternate system of clipboards and forms and pens, and paper, and someone typing all that, transcribing it in via typing into the system later.
Yeah, I think, one of the things that we think about is that if you're developing a use case, I'll just take the portal, a customer portal as an example, patient portal, right? There's going to be scenarios that you want to support where, Stephanie wants her data, but I also want my daughter's, I also want my dad's, I want my husband's. So that use case is a one-to-many, and we need to build for it. Same is true if you are, let's say, a caretaker going to 10 elderly people's homes and you need to visit them. There's no reason you can't use that exact same technology use case to, do as you said and bring the technology to the people, right? And in my mind, those are the things that we need to think about as we're addressing, what these big populations need and how we use data to get smarter about that. So, there's a lot of different ways that we can think about leveraging data, leveraging different kinds of data that we might don't traditionally think about as health data. So while we wrap up, let me click this little guy here.
May I go on?
Please. So just one more mentee
anytime
while
I'm
we're
on
talking.
stage, I want to rail about the inequality. I'll bet you 90% of all Fortune 500 companies probably have a behavioral health app available to their employees. There's probably a nutritional counseling or diabetes management app, et cetera. If you're on Medicaid, if you're on Medicare, CMS, the government does not reimburse against digital health apps. So we're talking about challenges with access, and you're depressed and you're on Medicaid. the face-to-face visit is the only thing you can get. You've got to take the bus. So the most challenged people in society to access a clinician and wait, the duration, don't have access to these technology tools because they are not reimbursed by CMS. So I would love to see Medicaid, Medicare start covering digital health apps, tools, telehealth services, these services that would benefit the most challenged to technically access, and they're not available. So that's just poor design by society, and that needs to change.
I think that's a fantastic point. And, you all can do this exercise. I do it, I don't know, every few months or so. Look in the App Store and look at the category for health or look at the category for wellness and see what kind of apps are the ones that are most downloaded, that are being most used. You've got one category that I'll just call captive, and, that's you need to use it to see your doctor because that is the portal that they use. You've got a category that's chronic disease management of whatever sort. Here's your diabetes app. Here's your, but by and large, if you look at that, the majority of the apps are weight loss, fitness, and frankly, marijuana finders was actually a really big category there. So, there's a lot of opportunity, I would say, to think differently, to your point about how we address populations that are not necessarily the ones who are looking in the App Store and trying to find a solution. So as we wrap up here, we're getting some different data types. That's good. Maybe one last thought about where the future of consumerism in healthcare is going, and then we'll open up to the audience for some questions. So Mike, do you want to start?
Well, I think, Amazon's nailed consumerism. It's cost and convenience. So you have to provide lower cost, more convenient options to individuals. They're looking and they will find that. So if you're not offering it, they're going to route and go somewhere else. And so incumbents, which we serve here. Oracle, typically sells to large, corporations. I sell to hospital systems with Zeal. You have to be addressing these changing consumer behaviors, and if you're not, you're going to lose your market share, and then you're just going to be that expensive hospital on the hill dealing with the ED trauma, centers. So it's incumbent upon you to shift, change, become more consumer-oriented, hire the marketing expertise, hire the digital expertise to build that consumer strategy, and then commit the resources to fulfill against that.
That's a great one. Hello?
Yeah, I would just echo that. I think, I just go back to that first story about Uber and taxis. Someone's going to come along and going to give patients and providers, clinicians, an experience that they're like, this feels better. This feels better. Like this, I feel safer. I feel on the patient side and on the provider side, I feel like this is why I came to do my job. And I think when that happens, patients and providers will flock to it. And I am convinced it does not have to come at the expense of, there being a way to pay for it. I don't believe it. I don't believe there's a problem that society will crumble, that the stock market will tank. I don't agree. I think just if we focus on if we focus on not designing solutions that are there. That are not focused on those two populations, that are there to enrich others, but that are there to enrich those populations' experiences, then I think the business gets the privilege of existing in that space, has earned the right to exist in that space because it's providing that service for those populations and for society. And that's why I do what I do, why I'm at Oracle. Yep.
Yeah, and I think, if I were to throw in my thoughts here, I try to look at everything we're doing as though you want to bring point of care closer and closer to the human, whatever that means, at home, if that means, at a community center, if it means whatever it means. But that more and more local experience should be fueled by increasingly global data, more and more information, more and more access to expertise that is not necessarily local. And I think in order for us to be able to get there, everyone needs to start thinking differently about their own data. You need to be willing to share it. Health systems need to be willing to share it. They need to be able to say, yes, we'll contribute this body of knowledge, even if it's de-identified, anonymized, et cetera. And until we all are willing to collaborate that way, we're going to continue to have the kinds of barriers that don't let us really realize the full extent of the vision that we just talked about here on this stage today. So, all right, well, let us see what y'all think. So let's open up for questions. Yeah, please.
Hi, thank you guys for a nice session. I'm John Hanks. I'm a professor, data scientist, engineer, startup person. And when I think about this problem, you have heightened my frustration.
Good. We want to get you angry. That's great. Yeah.
Talk to your congressman.
And this is kind of a different angle at it. If I'm solving this problem from an engineer's or scientist perspective, I'm like, gosh, this U.S. system is the most complex system that is in the world. Right? And here's the silo data problem. I've got my general practitioner that has an outcomes. My vascular specialist has outcomes in that space. Quest Labs has my medical, my data for my blood. And I call them to get my data, and it's, can you email it to me? Well, no. Can you have open API? No. I can fax it to you. All right. So.
With the fax machine we all have, yes.
That's right. That's right. So the silo data, the incentives of the providers and the payers are so complex in this environment. My thought is like, we've got to start in a simpler place where we can control these variables. Iceland, Sweden, Denmark or Norway, have you seen, where in the world are they closer to a solution that breaks down the barriers of data silos and solving the problem through managing the incentives better? So what are your thoughts?
That's a great question. I think speaking from what I've seen, I feel like if we took the best lessons from the different regions, countries, and governments, everyone's approaching it slightly differently, and there are places where, and I'm actually unfortunately going to forget where, but I just had a conversation last week with someone who was talking about, and like I said, I forget where they were, but the efficiency of vaccination, just as an example, rather than making an appointment, rather than showing up and having to fill something out and then wait for the vaccination and then tell them what your symptoms were afterwards. It was almost like a manufacturing process. So they had optimized the efficiency of the process. So you were queued up, you had your sleeve rolled up, everything was there already, and you just kind of walk through the line, and they did actually use manufacturing process as underpinning for how to build that flow. I think there are probably thousands of examples like that if you look at different practices across the globe. And I think, again, sort of back to maybe one of the frustrating points is being able to get to a place where we are all collaborating to share those things and adopt them when we know that it's a best practice, despite perhaps, or, around what those regulations and policies are that are different region by region and country by country. I don't know if you guys have any other examples or...
We operate just in the U.S. We haven't gone international yet, but socialized medicine, single payer, national patient ID, and that national patient ID can serve as the matching to multiple data sets. And for a variety of reasons, we don't have that in the U.S. And so that stymies levels of data integration and data synthesis across multiple domains. Not to mention business.
When you just think about retail, like how long did we struggle in the retail industry to get to single view of customer, just to combine your loyalty login and your brand login, and we're trying to get to a single view of patient with longitudinal records, and to your point, that's not even something we can do necessarily in country yet. Yes?
Hi, I'm Shashank Nayak. I'm a preventive medicine resident physician going into clinical informatics. So at first I wanted to say that everything that you said, Hillel, was really resonated with me as a physician. It's really nice to hear probably the best experiences I've ever had as a physician have been really connecting with the patient and making sure that I can reduce their anxiety as much as possible and really feel that they're connecting. And I think sometimes I worry that there are too many people involved in healthcare that really don't care about what's most important, which is the patient. And so it's really nice to hear that there are people involved that care about that stuff. So the thing I kind of wanted to ask is a little bit more specific regarding the ambient voice technology that listens in on physicians, which I think we were talking yesterday. I think that stuff's really, really cool. But I was curious, are there any concerns about like false positives? I know as a physician, when I like to brainstorm my thought process with my patient because I think it's really important to, like you're saying, that information asymmetry. I think it's the job of the doctor to mitigate that as much as possible. And so sometimes I'll go over, oh, it may be this, it may be that, especially if I don't know what the problem is. And are there any concerns about some of that stuff getting picked up and potentially screwing up some of the documentation? Is that something that's taken into account?
Yeah, absolutely. I mean, I think no differently than when doctors would speak into those little recorders with the mini tapes and someone would be transcribing them, which by the way was one of my first jobs when I was like 21 at a neurology department, typing up sleep apnea notes. And I think that's why even back then the doctor would review the note. And I think we have to employ the same things. I think that we cannot, none of this technology is a replacement for you, and nor should it be, right? It's there to take away mundanity, right? To take away rote things that you shouldn't have to do and to make your life easy. And even the AI that feels so humanistic, I'll say sometimes, is really just summarizing things in a friendly way and kind of trying to emulate a modality that is more comfortable for us, right? It's not us. It's not. It's technology. And that's okay. That's okay. So I think at every step, it's incumbent upon those of us making the technology to just go slow, still be excited, still be passionate, still bring it to the right place at the right time in the right way, but to always say, hey, this is what I think you were saying, doctor. Could you confirm that this is exactly what you're looking for? And I think we'll learn over time together. This is not, we're not at the destination. We're going to learn. Why, even spell check, it's not 100%. It's pretty close. It's pretty close. And the only reason we get away with putting those squiggly lines all over your Word document is because it is 99.89% right. Otherwise, you would be so irritated. You'd just be like, get these lines out of here. They're just wrong half the time. But the fact that it's so close to 100% and effectively 100% is why you even put up with its graffiti all over your document. So that's why I think we are on a journey together, and I think it's incumbent upon us to be thoughtful and intentional and responsible and ultimately trust ourselves, right? And look at technology as the assistant that it is, not as the end solution.
Yeah, I just to maybe add to that for 1 second, that I think when we use technology to be the assistant, to use your word, it's not just in the cases like ambient listening where we're capturing things, but applying the same patterns that we see in other places to health. So, for example, back to your tetanus shot example, you try to get life insurance or whatever, they're going to ask you every doctor you've seen for the last 5 years. I don't know. Who knows that? To your point, who knows that information? However, if you're trying to get something or get credit, it will say to you, are these the addresses you've lived at, right? it's about being able to present the information that's relevant and then have them validate that it's true rather than present the information as a fact. And I think that's the mentality that we need to be in, which is make it easier for people to say yes or no, this is right or wrong, or I agree or disagree, but don't make the decision for them. And so maybe just as an underlying philosophy to that's how we have to build and how we have to think. Okay. Maybe one last question. Nope, I'm getting that. Okay, we're not going to do that. No problem. Well, then let me say thank you because we are very excited to have you with us, not only for this session, but we do have 2 other sessions coming up in this room. One at 2 o'clock, 4 o'clock, 2 o'clock. 2 o'clock and 4 o'clock, I think, and then we're going to have a reception around 5 o'clock. So we would love to have you join us for the reception. We'll be there to chat further. And so thank you guys for joining. And right before I wrap up, I will say that it would be remiss of me not to say Happy International Women's Day. So to the women in the audience, big thanks. So big thanks to my panelists. Thank you both for joining. This was a really fun conversation.
Thank you to our fearless leader, Stephanie.
I hope it was fun. Hope it was fun for you all. And if you would like, we are going to take a picture for the women in the room. If you'd like to join us, we're going to take a picture before we head out. So please come on up, represent. Thank y'all.